Welcome to this section on cardiac rhythm recognition. Within this next part of the module, we wish to share with you a systematic approach to interpreting cardiac rhythms. The objectives of what we are going to cover in this part are to allow you to understand the 6-stage approach to rhythm recognition, and then to apply this approach to a series of rhythm strips to identify common arrhythmias. It may be useful to take a few moments just to reflect back on the normal conduction system of the heart, referring back to the Cardiac Investigations 1 module, and to remind yourself of where the normal pacemaker, the sinoatrial node, is situated, its normal rate of depolarization or firing, how the impulses are then transmitted to and through the AV node, and then rapidly down the specialized conduction tissue to the bundle of His, the right and left bundle branches, and the Purkinje fibers throughout the ventricular myocardium. It may also be helpful to take a moment or two to think about what types of patients in your area you might monitor and why. One of the commonest reasons for cardiac monitoring is to identify the patient's underlying cardiac rhythm. Cardiac monitoring may allow the early detection and management of potential life-threatening arrhythmias, allowing prompt treatment to be initiated to prevent cardiac arrest. Patients who are at risk of a cardiac event are also often monitored, and these include those who present with chest pain, collapse, syncope, palpitations, shock, following cardiac arrest, or who may be undergoing some kind of treatment and require monitoring for the duration of that treatment. It's important to remember, however, that cardiac monitoring only tells us about the electrical activity of the heart and not its mechanical function. Therefore, even when we can see a rhythm strip that we expect to be associated with a good cardiac output, we could have a patient with no cardiac output, i.e. in cardiac arrest. Alternatively, we may see a rhythm on a cardiac monitor which we think is ventricular fibrillation, or VF, a life-threatening rhythm, and find that on examining the patient it is only artifact. It is also important to remember that cardiac monitoring will not reliably detect the presence of cardiac ischemia. To determine this, or the presence of myocardial infarction, you would need to record a 12-lead ECG. With those thoughts in mind then, we are going to move on and consider how to read a rhythm strip using this 6-stage approach. The first question you should consider in looking at any rhythm strip on the screen is there any coordinated electrical activity? That is that you would expect to be associated with a cardiac output. We have chosen to add the word coordinated because even in a life-threatening arrhythmia such as VF, there is electrical activity on the screen. However, this activity is chaotic, variable, and not coordinated. The next thing you want to ask is, what is the ventricular rate? This information may appear on your cardiac monitor. If it does not, you may have to print off a strip and calculate the heart rate. The normal ventricular rate should range between 60 and 100 beats per minute. Therefore, anything that is below 60 would be a bradycardia, and anything that is above 100 would be a tachycardia. Are the QRS complexes regular or irregular? Sometimes it's difficult to determine this on a screen, particularly if the rhythm is very fast. Therefore, it can be helpful to print off a strip where possible, and by using a piece of paper, mark the position of 2 or 3 QRS complexes, then move this along to determine if these match up further along the strip. If they do match, this means the rhythm is regular. Regularity can be helpful in determining the particular rhythm you're dealing with. Also, if the rhythm is irregular, you should consider whether this is regularly irregular. That is, can you see a pattern forming? Is the QRS width abnormal or prolonged? Remember that the normal QRS should be less than 0.12 seconds, or 3 small squares on ECG paper. If it is longer than 3 small squares or 0.12 seconds, then it is telling us there is some delay in conduction through the ventricle. For the purposes of rhythm interpretation, we are going to consider that any broad QRS complex, greater than 0.12 seconds, is likely to have been initiated in the ventricle. On the other hand, A narrow complex that falls within the normal range of less than 0.12 seconds or 3 small squares will have been initiated in either the AV node or above, that is, in the atria, and rapidly conducted down the specialised tissues. Is there atrial activity present? So can you see P waves? Are they upright and rounded as you'd expect? If you can't see P waves, is there any other evidence of atrial activity? For example, fibrillation or flutter waves. And finally, if there are P waves or other atrial activity present, we then want to consider if this is related to the ventricular activity. So, for example, is there one P wave before each QRS complex? If not, can you see any pattern emerging or delay occurring? So having answered these 6 simple questions, you should be able to try to interpret or at least describe any rhythm you are presented with. Remember, even if you don't always get the name of the rhythm correct, you would be able to describe what you are seeing on the cardiac monitor, share this information with a more experienced colleague, and allow them to make the interpretation of the rhythm.